nephrotic syndrome can be caused by the systemic diseases. Again, lupus, Hep B, diabetes, and it can be just idiopathic. Nobody knows where it came from. Inflammatory changes may result in basically what our concern is: increased capillary permeability. And capillary permeability, we start losing protein and proteinuria, albumin is lost, and lipiduria, fats are lost, and patient will present with hypoalbuminemia. And because of that, like we mentioned before, patient will present with massive generalized edema, very puffy, very and it's not like dependent edema, it's very massive and very generalized all over. The level of protein in the urine may lead you to conclusion that the glomerular filtration is truly impaired, because the idea is that glomerular capillaries are so permeable. Unfortunately, they are so permeable, so your albumin is just slipping right into that. And again, urine getting dark and cloudy, smoky and coffee colored. And smoky maybe is the difference of again, from hepatitis. Usually hepatitis, like high bilirubin concentration in the urine, may result in in transparent but dark brown urine. Here, if you see smoky isn't hepatitis. Smoky and dark urine is glomerulonephritis. Okay. Immunoglobulins will slip into urine as well, and the problem with this is that patient losing immunoglobulins, and immunoglobulins are there for a reason, so for immune system. And if there is no immunoglobulin or low level of immunoglobulin, we lost them in urine, and conclusion is you can go to it deductively say that immunity level is impaired. So the last word here, well, you'll have all these findings: low albumin in the blood, edema, and lipiduria, and also hyperlipidemia. Why this hyperlipidemia occurs? Because to compensate for the loss of fat and protein in the urine, liver will increase the albumin production, synthetic function of the liver, as well as triglyceride and cholesterol production. So in addition to all these problems you already had with glomerulonephritis, like it wasn't enough, you have increased risk to develop hyperlipidemia, or patient will have hyperlipidemia with consequences of developing atherosclerosis. So causes, again, of glomerulonephritis are the same as let's talk about renal failure. And renal failure can be acute and chronic. Again, difference between acute and chronic, we all know that acute is rapid, chronic is slow, maybe progressive, but it may take years to develop into full-blown disease, not only in renal failure but everywhere else. So, but acute renal failure may progress within hours, But the good thing about acute failure, it may be reversible, and the bad news about chronic, it's usually irreversible. So, but acute will occur quite rapidly, and it's abrupt reduction in renal failure, renal function, I'm sorry. Let's talk about azotemia, and azotemia is virtually increased urea levels in the blood, and increased creatinine levels probably. Again, azotemia, it's increased urea and possibly creatinine level, and I'll talk a little bit about labs. Uremia is elevated urea and creatinine levels with fatigue, anorexia, nausea, vomiting, edema, in neurologic changes. I would like for you guys be very careful with these two terms. Usually, this is the only reason I really put it here, because people still use this, and they really nowadays use interchangeably. In both senses, it increases blood urea, nitrogen. Creatinine does not have to do anything with kidneys. Creatinine is a convenient substance to measure kidney function. Well, I said it doesn't have to do anything with kidney. It doesn't come from kidneys, what I meant. Creatinine is the muscle breakdown product. So you don't know really what creatinine means unless you look at the patient. Like, you know, when you calculate your GFR, your glomerular filtration rate, you would have, and your lab will actually do it in most places, would put into consideration patient weight and sex, and some of them even will include like race to make a correction on it. So why this happens? Creatinine is the muscle breakdown product. So if you have more muscle, bulk, you'll have higher creatinine level. So high muscle bulk, there is more and more body of knowledge that ties genetics, racial makeup, and gender into the creatinine level. So it's a well-known fact that African Americans would have higher level of creatinine because of the higher level of muscle bulk. Males have higher level of creatinine because of the higher level of muscle bulk, and females will have lower level of creatinine because of lower level of muscle bulk. So this is all really about how much muscle you have and how much is broken down continuously. Creatinine may be falsely elevated because creatine coming from muscles, and creatinine is the breakdown product. Creatine is a supplement very popular in sports training, which widely sold and consumed by many professional and amateur athletes. And if patients consume lots of creatine, then creatinine levels will artificially get elevated because they basically peeing out the unused supplement. And the usefulness of creatine as supplement somewhat questionable maybe, but there were many studies done and still it's inconclusive. Some would say that this is harmful for kidneys, the others say well not. But what I'm trying to say here, if someone has creatine supplementation, their creatinine levels will go high. So when you're talking about azotemia and uremia, always remember, yes, we mentioned creatinine levels, but if we are precise, azotemia and uremia, these are phenomena related only to blood urea nitrogen, or BUN. And BUN, saying this is a BUN, it's not approved abbreviation, again can induce furiousness and anger or sadness of someone you talk in, I don't know, your attending physician or fellow nurse. So don't say BUN, say BUN, just my piece of advice. And I you know, so it's better, and not only better, the correct way to abbreviate it, say BUN. So here, azotemia and uremia. Azotemia is just increased BUN, and uremia is increased BUN. Also, the consequences and signs and symptoms which are listed here. Acute renal failure, and there are 3 different types of renal failure. You need to know, you need to memorize. Hopefully you already had some exposure to these concepts before. If not, there's nothing to worry, we'll go over them right now. So pre-renal, renal or intrarenal, and post-renal. So 3 types: pre-renal, intrarenal, and post-renal. Okay, pre-renal is the most common type of acute renal failure. So what's pre-renal? Before kidney. Before kidney, you have impaired renal blood flow. And what happened? It's like heart attack for kidneys, kinda, not really. But what happened? The renal blood flow drastically reduced. Okay, pre-renal. Classic example, it's obstruction by a tumor pressing on renal vessels, and just kidney doesn't have any perfusion. Okay, if there is no blood coming in, GFR, glomerular filtration rate, declines because of the decrease in filtration pressure. Okay, that's makes sense, right? So if there is no pressure there in the pipes, then it's oliguria again. So acute renal failure, oliguria, patient doesn't produce something, so something to be concerned about. Again, oliguria, not good sign, as I said before. Ischemia is heart attack, myocardial infarction, may lead to hypoxia and hypoxic injury and infarction, and acute tubular necrosis, basically infarction of the tubules. So again, this is pre-renal failure. Pre-renal, renal, and post-renal. This is one of the most important concepts and in this lecture to distinguish between these 3 types of failures. Pre-renal failure trigger is not in the kidneys, it's outside, it's in the blood supply to kidneys. So whatever, if you want to fix this, fix that, whatever pressing on your blood vessels pre-renally, or maybe there is a tumor, maybe there is a something like a plaque inside of the vessel. So this all needs to be addressed to reverse it. Intrarenal is the second type of renal failure, and intrarenal, or some would say just renal acute renal failure, it's damage to actual renal parenchyma, and acute tubular necrosis can happen. So let's imagine this: you have a big tumor pressing on renal vessels, and what happened? It led to acute tubular necrosis. So our pre-renal failure turned into intrarenal. So we can call it into two type: post-ischemic, like the first case I described, just not enough blood supply, so pre-renal failure turning into renal. And the second one is nephrotoxic injury. There are millions of drugs there that's nephrotoxic, and the first one that comes to mind is gentamicin, and lots of other drugs. Also, cortical necrosis can be happening, acute glomerulonephritis, again, anything that kills whatever parenchyma is in the cell, in the kidney, that leads to intrarenal failure. But if you don't know exactly what it is, how to name it, think about it. Where's the source of this dysfunction? Is it before kidney? Is it inside of the kidney, or it's after kidney? So vascular disease also can be a reason for this. Malignant hypertension. As a matter of fact, hypertension is one of the main reasons people go to dialysis in this country. So toxic injury, again, like drugs and nephrotoxin. So it's all leads to intrarenal acute renal failure.